CEO of Cobble Hill Life Care, and we are a skilled nursing facility down on Henry Street, and also what we're here to talk about today, which is skilled care in the home. It's providing skilled services in folks' homes. Even though, although I feel like there's a few familiar faces out here, maybe just from bumping into you on the street or passing by. Even though I actually live in New Jersey, I've spent the past 24 years on Henry Street every single day. So I feel like I'm a neighbor. I feel like I'm actually one of the community. It's an honor to be here. It's a pleasure to be here. And I'll just introduce, I think our topic today is you don't have to go it alone. And I want to tell you why this is, and I'm not exaggerating, my favorite topic to talk about. And that's because I wish that I could go to the tops of every tall building in the world and to scream out that there are services available to all of us to help us keep us in our homes as we age. Isn't that amazing?
Yes, it is.
And I want to say one word about age, about aging, right? Because I know there's so much fear about it, right? There's so much talked about it in a negative context. I was literally just talking to a friend and a board member the other day, who's a physician, and he said, we were talking about aging, and he said that recently the World Health Congress, it named aging as a disease. As a disease that could be treated like all other diseases, with the hope of one day eliminating the disease, so we can live forever. Now, I don't know if that's a good thing or a bad thing, everyone can decide for themselves. But when thinking about aging, I said to him, and actually, Joan Millman, who's right over here, who is a board member, who helped put this together, and also I want to digress for 1 second, and also thank Shelley Holtzberg. Where's Shelley? Shelley, thank you. Thank you, and thank Joan for helping to put this together today. Anyway, to get back to the story, I said aging to me is like fine wine, right? We only get better as we age. Doesn't it feel that way? Oh, God. Well, that's why we're here to talk today, because our goal is to make you feel better, so that, in fact, that's how it feels to you. Okay? So without any further ado, I want to introduce Dimitri and Ruth. They'll introduce themselves, but I hope that tonight will be we'll relay some information to you. We'll give some time to ask some questions. We'll talk about what we do and what other institutions like ours do. We're not going to go till 6. I doubt, although we'll be here if there are any questions after. I just want to set expectations so you're not all watching your clock and saying, oh my gosh, there's so much more to go. Okay? All right, here's Dimitri.
My name is Dimitri Sadnov. I'm the Director Administrator of the Your Choice at Home CHA, Certified Home Health Agency. We're part of Cobble, and we are here to give you a quick overview of what we do, how we can help. So our mission is to provide support and assistance to our patients for them to stay happy and healthy in their own home. Our mission is to prevent hospitalizations, prevent rehospitalizations by providing skilled services. Now, what are the skilled services we provide? We provide nursing, physical, occupational, and speech therapies. These are the skilled services that we provide. The patients that we get, usually from the hospitals, nursing homes, and the community. To be qualified for the program, the patient needs to have something happen to them, meaning that we call it a skilled need. Maybe was an acute episode, hospitalization, fall, new diagnosis, medication, something happened. So that's what we call as a skilled need. That's the first qualification to be on the program. Second qualification is the patient needs to be homebound. Homebound means that there needs to be a taxing effort to leave home. The patient is unable to leave home by themselves. And the third is the patient needs to be under the care of the physician. So these are 3 qualifications to be on a home care program. Now, what conditions we treat? We treat all kind of conditions, from cardiac, respiratory, wounds, complicated wounds, all kind of conditions, but diabetes, of course. Specifically, like I mentioned, our goal is to prevent hospitalization. We want our patients to stay home. We want them to be happy and healthy. Now, what am I supposed to? Yes, I'm sorry. Let me introduce Ruth. Ruth, here you go.
Hi everyone, I'm Ruth. I'm the operations manager of Your Twist at Home Cha. My job, my responsibility is mainly to make sure that the services you guys are receiving is smooth. The transition is smooth, everything. If you have any questions about your services, when it will start, that information for you guys.
All right, thank you. Okay, so now you've met Dimitri and Ruth. And Dimitri started to go into it, but I wanna go back for a moment, because I know it can take a lot to kind of digest. I wanna make sure that when everyone leaves here today, that you have a really clear understanding of what a CHA, a Certified Home Health Agency, can do for you, or for friends, or for loved ones, and you know how to access those services. Now, I will say one thing before we continue, is that even though we represent Your Choice at Home, which is a specific agency, what we're saying now applies to all certified home health agencies, okay? So in full transparency, if you go to any certified home health agency, they should offer the same services, okay? All right, so I wanna start again, just kind of going back one step. Dimitri, can you explain one more time what a CHA is? What kind of skilled services someone can receive in their home through an agency like ours?
So the skill services that we provide is nursing, therapies, physical occupational therapies. That's the skill services, nursing and therapies. As far as,
Speech?
yes, speech as well. So physical, occupational, and speech. It all depends on the condition. We create the care plan based on the individual patient condition. We work closely with physicians to make sure that we provide as much service as we can under the patient's insurances. So these are the skilled services that we provide.
Okay, great. So nursing services, physical therapy services, occupational therapy services, and speech therapy. Okay, those are the types of care of professionals that we send into someone's home. Okay, so let's now go the next step. Let's talk about some scenarios of what might be in place that should make someone think about calling a CHA. Okay, so the first obvious one is if someone is in the hospital. Let's say somebody is in the hospital because something happened to them, and they're ready to be discharged from the hospital. Now, they have a couple of options in front of them. One option, right, is to go to a skilled nursing facility if they're unable to go home. Today we're talking about when one can go home, but one needs some services and support to go home so that they can stay successfully back in their home, back in the community. Dimitri and Ruth, can you talk a little bit about a scenario like that? What someone might have been in the hospital for, and how that transition works back home from the hospital with services like ours.
And once once we see the patients had a fall, they've been in the hospital, they're debilitated, they need some help. So that's the typical patient that we see very common. Now, we provide nursing, therapies to make sure that the patient is safe. We also provide, which is called the home modification program, where our therapists assess the home for safety. We look what equipment they need. Maybe they need, ramps, grab bars, all the equipment, whatever they need in the bathroom, and we order this equipment for our patients. So we want to make sure we prevent any future falls and stuff like that. The other typical patient that comes to a hospital, the patient had some kind of a cardiac problem. Yes, I'm sorry.
So I want to make sure we're really clear. So before we move on to the other type of scenario, I want to just, so let's say someone is coming out of the hospital after a fall. They may have had surgery. There may be a wound. right, as a result of that surgery. So when the patient comes home, they need a nurse to come to dress the wound, to make sure that the wound doesn't get infected, to give medications. In addition, the individual needs to have physical therapy. They need to resume walking, right? Walking is such a critical part of our health, right? When we're immobile, when we're bedbound, right? That's not the healthiest place for us to be. Sometimes we have to be in that place for some time, but the goal is to get us back on our feet, back walking, right? It's about living. That's what this program is about. It's about living. So we send in our therapists to walk a patient, to help them transfer from bed to chair, to how to use the bathroom, to how to shower, to bathe. Am I saying that right? All right, he's keeping me honest here. In addition, Dimitri mentioned home safety is very, very important. Because oftentimes, and we've seen this many times, people fall in the home, right? Now, I've seen many homes over the course of my almost 25 years in doing this work. And let's just say there are some homes that are very, very neat and organized, and there are some that are less so. No judgment, right? Now, don't look at my office. You'll know where I fall on the spectrum. Joan knows, she's shaking her head because she's been there, she's seen it. Lots of piles of papers, right? But sometimes, right, when we're able to move freely, that's wonderful. But sometimes when we're a little bit more frail, and our foot catches on the carpet, or it catches at the threshold into a bathroom or into another room, right? And there's a fall. So we send in our team to look at your home and to say, what modifications can we make with you to make it safer? That could be something as simple as organizing a little bit differently, to take things out of the way that might be a tripping hazard. It might be looking at the bathroom and recommending and installing a grab bar in the shower. A grab bar, everyone know what a grab bar is? Yeah. Okay, good. It might be other, non-slip or, fall prevention devices to make sure that there's nothing slippery, right? And how does the line go? You guys help me. An ounce of prevention is worth a pound of cure, right? The idea is let's look proactively and let's figure out how to make your home as safe as could be so that you don't unwittingly end up falling, either initially or again once the person is back home, okay? So that's one example that in a case of coming out of the hospital, from a fall, a fracture, surgery of some sort, where there's a wound, we want to make sure that the nurses come in, we want to make sure that infection doesn't take hold of the wound. We want to make sure that that surgical site is clean and gorgeous. That's what we want to make sure. Secondly, we want to make sure that we get people back on their feet, that we're able to walk, we're able to use our hands and our legs, our extremities. We want to make sure that activities of daily living, all the things that we need to do every single day, we're able to do with increasing ease and comfort. And thirdly, we want to make sure that the home environment is as safe as could be to promote independence, to promote living in the community. Okay? All right, now we're going to go on to another scenario.
Another typical scenario is when the patient had some kind of a cardiac condition, either heart attack or exacerbation of some kind of a pre-existing condition, where they went to the hospital for a short period of time and now they're ready to come home. Now, with these kind of patients, the main service that we provide is nursing. We want to make sure that we know that the most likely medication has been changed, adjusted from the medication the patient used to take prior to hospitalization. So we want to go over all the medications. We want to make sure that our patients take medication they're supposed to be taking. A lot of times we find that, especially when patient comes out the hospital or the skilled nursing facility, they still have all medication bottles in their homes, and now they have new prescriptions, and they don't know what to take. They take everything, and a lot of times they double up on medications. A lot of times it's same medication, different names. So our goal is to make sure that we get there, our nurse gets there as soon as possible to reconcile medication. Make sure that we tell the patient exactly what they need to take. And by the way, this is also one of the main reasons why patients go back to the hospital shortly after hospitalization. Medications, simple as that. So our goal, we do medication reconciliation. We tell our patients exactly what they need to take. All right, so that's another typical scenario. Now, because the patient came to us with cardiac condition, and such condition, for example, congestive heart failure is one of them, we monitor closely the patient. We monitor the patient weight. We monitor the patient edema or the swelling, making sure that we identify early signs of decompensation and prevent hospitalizations. Because for most part, all we have to do is just, if our nurse recognizes or identifies something is wrong before the actual symptoms appear, we can prevent hospitalization. We call the physician, work very closely with physicians, and a physician over the phone adjusts medication. We tell our patients exactly what they need to take, and hospitalization avoided. Simple as that. So that's another typical scenario.
All right, thank you. So I just want to recap again. The goal is to make sure it's crystal clear to everybody, because we want everyone to know how to use these services. So I cannot speak enough about medication reconciliation. I've seen this with my own family members so many times, right? Where we go to one doctor and we get a prescription. And we go to another doctor, we get a different prescription. We go to the hospital for a procedure, we come home with a whole other list of prescriptions. And how often are we going through our bathroom, our medication chest to see what are we taking? Should some items be discontinued? Are there any contraindications between medications? We've seen, and this has been proven time and time again, it's irrefutable, that many people end up in the hospital, especially as we get older, because of our medications that we're taking. The very thing that we think is keeping us healthy, in the end, is actually doing us harm. So it's very important that we look through and take stock of what are the medications in our homes. What should we be taking? What should we not be taking? What are the doses, right? The dosages. And by the way, doing this once not enough. Were you just gonna say that?
No, well, the doctor says, come in for checkup,
Right.
blood work every 6 months sometimes. Don't wait a year.
Exactly. Don't wait a year. I'm gonna get to you in 1 second, sir, okay? The key is,
My hands off.
no, behind you.
Oh, all right.
No, I would not make that mistake. The point, and I think, what's your name? Sorry, in the front, what's your name?
My name?
Yeah,
Diane.
Diane.
Yeah.
Diane made a great point. Diane was saying that she goes to the doctor, or people go to the doctor. The doctor says, come in every 6 months, right? So we can do an exam and we can kind of refresh where we are. And that's amazing and wonderful, right? But what the doctor doesn't know all the time, unless we tell them, is what other medications we have in the house that a different doctor may have prescribed, right? So it's very important, I think, Diane, that's a great point, that I would recommend that whenever you go to the doctor, bring a list. Bring a list with you. Keep a list for yourself of the medications that you're taking, so even the ones that they may not have prescribed for you, you can tell them what you're taking and ask them, are there any contradictions, any contraindications? Are there anything you should be concerned about? And you'd be surprised. I've seen it many times where they say, oh, thank you so much for bringing it to my attention, because actually you're doubling up, right? One's a generic and one's a brand name, but it's the same medication. Or one, isn't indicated anymore because you were put on that, for some special condition you had at some point, but it's no longer necessary. Okay, question in the back, sir.
A family member of mine who's even older than me, who recently was in the hospital, diagnosed with pneumonia, has other conditions, came home, and now has people coming in, physical therapists, this one, that one, and she doesn't seem to have any idea who's coordinating all of this. What is the communication with the primary care physician, whoever, and, you know, and I put some of this maybe on her primary care physician too, because I don't see reaching out on that person's part either. So how is all this put together so the person just doesn't have a ring, 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 I'm here to do whatever?
Right. Okay, I'm gonna let Dimitri and Ruth answer that question.
Thank you.
Excellent question,
I
by the way.
appreciate it. Thank you.
And what's your name?
Phil.
Phil, thank you for that. Absolutely, yes, thank you. Phil's question is that a family member recently came over to the hospital with pneumonia, and the family member has services in the home. And a variety of specialists are coming in, nurses and physical therapists, occupational, all sorts of different disciplines. But his question is who's coordinating all that care? That it's not often clear to this loved one why they're coming, how everyone's working with everybody else, what the grand scheme, I'm paraphrasing, but that's the sense that I got, is that right? And in essence, and how is it all coming together into a cohesive kind of plan of care? And whether that's the role of the primary care physician, or whether that's the role of the agency who's sending in, the professionals. So it's an excellent question. We're gonna answer that now, and then we'll come back to some of the other stuff we wanted to talk about, because I think it's so important. But I would just like to say, before I give the mic over to Dimitri and Ruth to actually answer it, that you're raising an incredibly important point, which we're not gonna be able to solve, but I think it's important to give voice to the issue, which is, as many advancements as have been made in medicine today, the system is incredibly fragmented. It's incredible, and I hear some chuckles because everyone's experienced this, right? And I'll also plug advocating for ourselves, right? Because often a patient today in the system, the healthcare system in America, as good as it is, requires and demands advocacy. We need to speak up for ourselves, and we need to ask questions of our healthcare providers, even if it's us. I would say especially if it's us, because we really want you to. There's so much fragmentation where often it can be confusing. Who's actually treating me for what, right? As Phil was saying, why are they coming in? How does that affect me in the grand scheme of things? What are the big goals of the care that I'm getting, so that I'm not so confused by it, and I can actually see how it's gonna all fit like a puzzle and help me live my best life. Okay, Phil, thank you for asking that. I'm gonna turn the mic over to the expert.
They just come in, do what they need to do, and that's it. And no one knows what's happening, and is the patient achieving the goal, not achieving the goal, and this is a very common problem. To address that, we design our home care in a different way. All our nurses who come in and see patients, the official title is the nurse coordinators. So basically, these nurses coordinate your care. And on admission, when we first come in, the nurse introduces themselves, and they actually give our patient, the nurse's name, the contact information, all of that. Now, all the disciplines who are servicing the patient afterwards will report to that nurse coordinator, who will coordinate the services, communicate with the physician, and together will decide whether the patient needs an extension, whether the patient needs an increase in services, decrease in services, discharge, and all of that. So, to answer your question, in our child that doesn't exist, because all our nurses who see the patients, they actually nurse coordinators. So they are the ones who are responsible to make sure that whoever is servicing the patient are reporting to her, and we communicate. We call this interdisciplinary communication, what's happening, and therefore, if a family member calls us, the nurse coordinator can tell the patient family, this is what's happening, this is where we stand at this point, this is what we're trying to achieve, and that kind of stuff. So with our home care, that doesn't exist, basically. So that's how we designed our home care.
But for all of you, sorry about that. But for all of you who might, like Phil, like your loved one, who may have other agencies in there right now, I think going back to the advocacy question, if there's ever anything that you're just not sure of, ask the question. So what we would suggest is ask to speak to the nurse coordinator, okay? Ask to speak to that individual and ask them, how does it all come together to give you an overview of who's coming into one's home, what the role of each discipline is, what their specific goals are with your loved one, so that when you end the conversation, you have a clearer picture of how it all comes together. Okay? Now, while we're on this, I just wanted to ask Ruth, because Ruth, as she said, Ruth is doing a lot of the operations. She's making sure that everything runs really well in our agency. So, and you know, the other thing I'll say is that there is no, just like I'm not perfect, and just like, well, you're probably all perfect, but I'm not. But most organizations are flawed, right? And as we talked about, they're fragmented, and sometimes, despite an organization's best intentions to coordinate and to communicate, gaps form, right? Two people didn't get the message, and there's a gap, and we're not sure, you know, services, it was unclear. So, you know, that happens by us too. I think what differentiates us is that we jump on that as an opportunity to make things even better. But we've had in situations where there are gaps, right? Where there's confusion, right? Where the care maybe is not as coordinated as it can be. So Ruth, are there some situations that you could talk about, you know, where you helped in smoothing things out, where there may have been misunderstanding or confusion along the lines of care coordination, and how we were able to solve that for them?
Thank you, Donnie. Yes, so there have been situations where there's some confusion. Maybe the name of the therapist was wrong, or the nurse didn't have the proper contact information. So as soon on the intake packet that Dimitri is speaking about, where on the first visit, the admission visit, the nurse leaves in the home for the patient. There's the number for the agency. Our number for the agency is in the packet. You'll pick up the phone call. I'll be the one to pick up the phone, or one of my employees will be the one to pick up the phone, and they'll transfer to me. And I'll just I have direct contact to all of our vendors. So whether it's a confusion with physical therapy, occupational therapy, speech therapy, even with the nurse, it's just one phone call away. I'll pick up the phone and I'll smooth things over. I'll ask, you know, who's the actual therapist on this case providing services, and how long, how many visits they've provided, what are the goals, what are they doing, when is the next time they're going. You know, try to get deep and down into all of the details, so that by the time I can give you a call back, and we try to make sure that we give you a call back within 24 hours. We don't want you waiting days to get answers about your care. So we make it our motto to make sure that we give you a call back within 24 hours to get to the bottom of any issue that you guys do have.
Yes, go ahead, I'm sorry.
This is a basic question. When you're in the hospital, a social worker comes along and is gonna discharge you, just tells you what agency to use. How do we get in touch with you?
All you have to do is just tell them our name, and they will have no
okay.
choice but to get in touch with us.
Okay.
And we will leave information. And if anybody wants to leave their email address, we're happy to send follow-up information to you, so we can give you exactly what you need in a situation like that, so you can specifically request us.
Okay.
But again, this is about we want to empower you with knowledge, so no matter what agency you go to, you'll know how to advocate for yourselves and what to expect. Yes, sir.
I have actually two questions. First one, you described when the patient comes out of the hospital. Do you have different situations where a patient goes home alone to their own apartment, or where they go as a family and then live with people? It's could be a completely different kind of care situation. And the second question is, most people coming out of, I don't know about most, but many people coming out of hospitals today have MyChart and have complete hospital records of all medication and treatment and projections, all that available to them and to anybody they want. Do you guys go in and share that or obtain that information?
Okay, so let me work backwards.
Could repeat the question.
Yes, the question was number one. I'm going to work backwards. Second question was, many patients today have MyChart, and they have access to their medical records. And do we or other agencies have access to that as well? And the answer to that one is usually no. We usually do not have access to that. If a patient wants to share that with us, it's their choice to, but we don't automatically have that, right? We don't have access to that. What we get is the discharge paperwork from the hospital. And that's where we understand what the needs of the patient are, and that's how we plan our care around it. Now, we don't take that for granted, because when we start services, we send in a nurse to do our own assessment based on the hospital paperwork, and actually looking at the patient, looking at the individual, and talking with them or their loved ones. We put together a full picture of what the care needs are at that time, but we don't usually have access to your personal, medical record. Go ahead. Yeah, go, please.
So regarding the second question about MyChart, we do not have access to MyChart. However, we do have a clinical coordinator on site, and their responsibility is mainly coordinating your clinical documents with your physicians and any surgeons that you've seen lately, because we want to get, like Donnie said, the big picture. We want to see what's going on with your care over the span of time that you've been in the hospital. So we do have the clinical coordinators there that reach out to your primary care physicians. They reach out to the hospital, the surgeons, so that we can get a clear picture of your care, so that we can provide the best possible care to you that we can.
All right, thank you, Ruth. And then go back to your first question. The question is that someone who is in the hospital may go home to a variety of different situations. One might be they're going home to their home by themselves, where there's no one else living with them. Another one may be where they're going to their home and then maybe there is someone else living with them, a spouse or another close family member. Another one would be where they don't go back to their own home, but they actually go discharged from the hospital to the home of a family member, to kids, or to a sibling, or to somebody else. And what's your name? I'm sorry, sir. What's your name?
I'm Jeff.
Jeff. Jeff was asking us, how does that work? What are the differences in when a patient is discharged in those different types of situations? Did I get the question right?
Yes.
Okay. So the answer is that everything. Number one, a hospital may not discharge anybody if it is unsafe. Okay? They cannot. Which is why they will want to set up services with an agency like ours, because that's part of the safe discharge. So, and I also, just one other word, while we're talking about advocacy, because that's such an important part of healthcare today, is you should just know that if anyone is ever in the hospital and they're pushing you to discharge and you don't feel safe yet, you don't understand clearly what the plan is, you can say no. You do not have to just go along with what the hospital is forcing you to do. You can ask questions, you can escalate it to a supervisor. When you discharge or your loved one discharges home, you should know very clearly how you're going to go home safely, how you're going to stay home safely, what kind of services you're going to get in your home in order to remain safely in your home and continue to recuperate. Okay? So the answer is that we take a look at the individual, we see what the needs are, we have to make sure that it's safe. I will let you know that on occasion, we actually will send a complimentary aide, a home health aide, to escort a patient home from the hospital, because we know that first day is so important. It's so critical to getting somebody back in their home, making sure that there's something in the fridge, making sure that the medications are picked up from the pharmacy, making sure that someone's comfortable and settled in their bed. All those things are really important. So there are times when someone may not have family to help escort them home from the hospital, that we will, for no charge, we will send in a home health aide to the hospital and to help bring the individual home, because we know how important it is to get home on that first day. Now, one of the most important things is family involvement or friend involvement, right, in our lives. We want to be independent. We all want to be independent, right? But I think humans are social creatures, right? We're social animals. We need connection. We need involvement in our lives, especially during illness, post-hospitalization. It's a wonderful thing, when possible, to have others around to assist us in our care. So if we have the option of going to be with family members, I think it's something to consider strongly. When someone can move in with us for some time to help us, I think that's a wonderful thing. or friends to check in and to come in and to just offer some support is a wonderful thing. But Jeff, right? I'm terrible with names. That's why I ask. The short answer is that we're going to evaluate every patient as they're coming home from the hospital and what their specific situation is, and we're going to set up services accordingly to make sure that it's safe and that it's effective for them to continue their rehabilitation, to continue getting stronger and healthier, and to continue living life to the fullest. Okay? Now, you want to say something? Okay.
They went to stay with their family members for a short period of time, and then we were working with them. They got better, and they went back home. So to us, it really doesn't matter where the patient goes. We adjust the services based on their living environment and based on their condition. I also wanted to mention that when you or your loved one comes out of the hospital, just before the social worker comes to you and they say, okay, we're planning to discharge you on so-and-so date, please ask the social worker, when will my home care start? It's very important to ask that question. A lot of times, the social workers ask us for a specific start of care date. It's very important because then the social worker, she will call the home care agency and will ask for the start of care date. So you'll know when to expect someone. And if they don't show up, you can actually call back the social worker in the hospital and ask and tell them, where's my home care? It's a very common problem where home care doesn't start on time. There is a delay, or sometimes they never start. So demand the start of care date from the social worker when the start of care for the home care, the date. Very important.
So going back to what Dimitri just said and what Ruth was saying before, some of the common issues that could happen with coordination are that a service doesn't show up, right? Like Dimitri was just saying. So it's important to call to make sure that there wasn't a glitch, that they had the wrong phone number, that they had the wrong address, that they went to the neighbor instead of to you, things of that sort. One other thing that does happen from time to time is, we're humans, and sometimes we just don't like somebody, right? So an aide or a therapist may show up, and you just don't get a good vibe from them. I've had it with many people where, I have one family member call and say, this was the most wonderful therapist or nurse, and sing their praises, and the next one calls and says, who'd you send? So there's this is very intimate care, right? In one's home, right? Helping you get back on your feet. So it's very important also that it feels like a good fit, for whatever reasons. And I would say that you should be unapologetic about it. You should feel good about the caregivers coming into your home or into your loved ones' homes. And if it doesn't feel right to you, just advocate for a change. It happens all the time. Don't feel bad. Don't feel guilty. Just if it doesn't work, it's not working. And an agency should give you no problem and should just work to, if it's something that, if it's a misunderstanding and something could be resolved and talked through, that's great. But if it can't be and you're just not interested in it, just say so. And the agency should not hesitate to switch out, to switch it out. Yeah, hand all the way in the back.
I'm sorry, what about that individual who does not need skilled nursing?
Recommend is know your insurance. And don't wait for a crisis to first find out and start asking the questions. The better prepared we are, the easier it'll be to navigate, a crisis when one inevitably comes. So know your insurance, ask those questions in advance, know what your coverage will cover, so you can be prepared.
I'm sorry, I just forgot to say, so under Medicare, without the having a skilled service need, meaning without nursing, Medicare will not allow to cover HHA or home health aid. There has to be a skilled service. There's a Medicare guidelines in all 50 states. Same thing.
Well, insurance, about coverage for our services. Dimitri, do you mind telling us about how this is all paid for?
So the majority CHA or skilled services are covered under Medicare. and some Medicare plans, managed care plans, and we participate in a lot of them, from Health First, Emblem Health, MetroPlus, Humana, Aetna, many. VNS, we also have a contract. No Cigna. VNS Choice. We have a whole list that we can provide. And we are expanding the list of our contracts. But yes, so it's Medicare and managed care Medicare, and some commercial plans as well. We participate, as well as Medicaid and managed care Medicaid.
On staff, we have Mandarin, Cantonese, we have Russian, we have Spanish speaking, Creole. I forgot about myself. We have Creole, yes, and French.
By Medicare, and there's no out-of-pocket expenses whatsoever.
I see.
And that's
Perfect segue.
and perfect segue. But that's why. And I think. Remind me your name.
And
Ann.
the Advantage programs as well?
Medicare Advantage. Go ahead.
The Medicare Advantage programs are a bit different from the straight Medicare programs, in which sometimes depends on the plan you have, you may have a copay or you may have a deductible, but sometimes it shouldn't be as, you can reach out to your individual health plan and see what the copay or what the deductible. Sometimes you don't have any copays or deductibles, but some plans, specific plans do.
So first of all, I worked with Shelley and want to thank her, and with Toba to put together this amazing audience. We did something very similar where I live now, which is in Concord Village. And we had a nice turnout, but nothing like this. So you guys are amazing, and thank you for coming and giving up some time. So I was a recipient of the program. I had major surgery in 2019 and was in the hospital for many days, and came out and they asked me in the hospital before they discharged me, where would you like to go? And I now live in Concord Village, though I used to live here. And I wanted it, and my family lives all over the place. They live in Kingston, and there wasn't anybody close here. So I said Cobble Hill. So I went there, and I came on a gurney. And I was there for 3.5 weeks, and I got physical therapy, and I got occupational therapy, first in the bed, because I couldn't walk at all. And when I left 3.5 weeks later, I was using a walker. And they took me outside in the street and showed me how to navigate curb cuts and sidewalks where there weren't curb cuts. They asked me about stairs. They showed me how to use the stairs. In the rehab room, they had a bathtub, and they trained me how to get in and out, all right? And they ordered for me my walker, and they ordered other things for me that were home when I got home. And when I was ready to be discharged, somebody came to me and said to me, well, we have this program here, but you can take any program you want because you live alone and you can't go home without having services. So I picked the program from the place that I was at and was hoping for the best. I didn't know anybody who had used the services before, right? So I was the guinea pig. And I have to tell you, I had a visiting nurse who was wonderful. She came once a week and she took vital signs. She asked me questions. She took detailed notes. And before that even happened, I got a packet. And it told me, I didn't know if it was your name on it, Ruth, because I don't remember. I think I still have it because I don't throw anything away. But in the packet, it said, this is who you call, all right? I also had the services of a physical therapist, and she came twice a week. And the first thing she did when she came into my apartment was put that away, get rid of that. I had area rugs, a big tripping hazard. I didn't think about it, right? I had it. Also, she said, when you get up at night to go to the bathroom, which happens as you get older, how do you get there? Do you put on a light? Well, she said, get a night light. I mean, she went through my apartment and gave me real concrete tips. She said to me, do you have a stepladder? So I said, yes. She said, throw it out. Don't want you on a stepladder. If you don't have it in the house, you won't be tempted, right? Your balance isn't as good. So she was really top notch, and she had me doing things, and she said to me, because they don't have equipment, but they bring the things they can, a ball and things you can pick up. What she said to me was, you can do these exercises when I'm not here, but these other exercises don't do alone. Because you could trip and fall, someone has to be there. So when I would do those, then I would ask a friend, my neighbor, to come in, you know, and watch so that I wasn't doing them alone. And then I also was entitled to a couple of hours I got a home health care aid, because I couldn't shop. I couldn't pick anything up. I couldn't really walk outside for an extended period of time. And I have Medicare. I'm also, before I was the assembly member, I was a teacher, so I have retired teacher's insurance. And I didn't pay for anything out of pocket. I had no copay. If I had a copay, I would have had to pay that up front, I'm sure. But I didn't have that. And, you know, somebody up there was taking care of me, and here I am, and I have my full mobility back. And I couldn't say enough good things about the program. I clicked with the people that serviced me. At one point, the visiting nurse said, your services are about to be terminated because you had so many weeks, but I think you need an extra week. Would you like an extra week? So I didn't say no, right? I didn't say no. So I got the extra week, and then I was able to, you know, the people were just, the one thing that struck me is that the home health care aide, when she came, she asked to use my cell phone. She called her supervisor so that the supervisor knew she was where she should be. Right? When she left, whether we were outside or in the apartment or wherever we were, she used my phone to say that she was leaving. So they always knew that she was exactly where she should be. You know, so it made me feel that this is a well-run program, right? There's accountability. They're watching what they're doing, and I never had to call and complain about anything. It was an amazing experience, and I'm really very lucky in a lot of ways that I went through it, because I walk and I drive and I take care of my own needs by myself. And my brother is always telling me, do you want to move in? I don't want to move in with my brother. He's lovely and I love him, and he's married to a very nice lady, but they have their home and I have mine, and now I have my area res, but I did go and buy carpeting for my bedroom, because that's what she suggested. The visiting nurse said, that's not a bad thing to do, because you get up at night and you have wooden floors and you could slip very easily. So I did do that. That was an investment I made for my own future. You know, I thought about it. But anyway, I'll be around for a while if anybody wants to ask me anything else that I haven't covered. But if it's, hopefully you don't have to use it. But if you do, it's here, it's in the neighborhood, and the people are wonderful. Thank you.